Hello, everyone. I'm Pasi Jänne, from the Dana-Farber Cancer Institute in Boston, Massachusetts, and I'm also the director of the Chen-Huang Center for EGFR Mutant Lung Cancers. I'm joined today by my colleague, Dr. Julia Rotow, also from the Dana-Farber Cancer Institute, and we wanted to give a brief update on some of the happenings in EGFR mutant lung cancer that we learned from this year's ASCO meeting.
And Dr. Yanni, thanks for joining us today for this conversation. I think this is a great opportunity to talk about what's been happening in EGFR with some of the recent conference updates. And I thought we might focus today. I think both of us were interested in the new data in the EGFR exon 20 space, talking a bit about EGFR atypicals, so both addressing some of the uncommon EGFR mutations, and then touching a bit on some of the data for the novel PD-1 VEGF bispecifics and how that may impact our patients with EGFR mutant lung cancer in the future as well. So maybe to kick off our conversation, one of the biggest updates in the EGFR space had been the frontline data for sunvosertinib in the randomized Wukong 28 trial, looking at comparison to platinum doublet chemotherapy for patients with newly diagnosed lung cancer with an EGFR exon 20 insertion. Dr. Yanni, maybe you could take us a bit through the study or kind of implications for our patients with this subset of EGFR mutant disease.
Sure, I would be happy to. So, EGFR exon 20, just to remind everyone, is a subset of EGFR mutations, about 10 to 12% of all EGFR mutations. And currently, the frontline treatment for those diagnosed with advanced EGFR exon 20 mutant lung cancer is the combination of chemotherapy and amivantamab. We do have a second approval in the second line therapy, which is sunvosertinib, which is an oral EGFR kinase inhibitor. And at this year's ASCO, we learned the results of the first line trial where in previously untreated individuals, sunvosertinib was compared to chemotherapy as initial systemic therapy. And that trial was positive, whereby patients treated with sunvosertinib had a longer progression-free survival than those treated with platinum-based chemotherapy. Now, the side effects of sunvosertinib do include many of the more classical EGFR side effects like diarrhea and skin rash, but this certainly opens a new therapy or potential therapeutic option in the first line setting to have an oral agent compared to amivantamab and chemotherapy. At the moment, however, while sunvosertinib is technically approved in the United States for patients who have previously received treatment, it is not yet commercially available, and we hope that will happen sometime soon. And then we'll have sunvosertinib as another option in the frontline setting.
And of course, this is great news, I think, for our patients with this subset of EGFR. And for a long time, exon 20 insertions have been so challenging because we knew they were driver mutations for the cancer. We could identify them in testing. We found them many of the same populations as our more common EGFR mutations. We had no therapies available. And I think now we have not just one, but multiple classes of treatments that are available that can help to address this subset of the disease. So I think great news. And I share your hope that this will become available in a practical sense, logistically, in practice in the near future as well. Now, of course, exon 20 insertions are not our only uncommon EGFR mutation that we encounter. We also have all the atypical EGFR mutations. That's about 5 to 10% or so of our EGFR population. And with a similar challenge, I think historically we have agents that work against these. Certainly our first through third generation EGFR tyrosine kinase inhibitors are able to target these more uncommon but not exon 20 insertion EGFR mutations. We also know that both prospective and retrospective data sets have suggested overall lower response rates or shorter durability of effect compared to the activity of our current standard EGFR inhibitors against the more common classical EGFR mutations like exon 19 deletions and L858R. I think this is changing as well, right? There's a lot of work going on trying to understand how can we best target these uncommon or atypical EGFR mutations. And there we also had some updates. So I'll highlight maybe one class. I'll talk about maybe the novel kind of fourth generation and next generation EGFR inhibitors. And then Dr. Yanni might ask you about the amivantamab lazertinib data that we saw at ASCO. But I think one emerging class of drugs here has been the effort to develop novel EGFR inhibitors that are hopefully designed to go after some of these uncommon mutations and preserve some of the features we like of our current third generation drugs like CNS activity, and ideally preserve some of that tolerability if feasible as well. And we had data come out for a number of these at ASCO and at recent meetings. So agents like silevertinib that we were able to be a part of the trial showing activity, as well as CNS activity, which is good to see, though in small numbers, of course, in early phase studies, and I think still some toxicity profile that requires ongoing work to finesse dosing and optimal management. We've also seen data for some of our upfront current combinations with our current third generation available EGFR inhibitors. So I know we saw updated data from the amivantamab lazertinib Chrysalis-2 cohort come out at ASCO in one of the oral abstract sessions as well. I don't know, Pasi, what your thoughts were in terms of frontline selection or how we think about the uncommon EGFR mutations when choosing therapies.
Thank you. Yeah, that the Chrysalis-2 cohort from the amivantamab lazertinib trial specifically evaluated that combination, which is approved as first-line treatment for the more common EGFR mutations based on the Mariposa trial. Also, so it was evaluated as a therapy for the uncommon EGFR mutations, and what we saw at ASCO was a longer-term follow-up with the overall survival, and the data do look encouraging for that subset of EGFR mutations as well. So I think it does provide an alternative approach or an additional approach and strategy for treatment of this class of EGFR mutant lung cancer that has historically been a bit challenging to treat.
In some ways, I think frontline decision making for this subset of mutations is really tricky, right? We have all our three standard frontline options that we still think about, even for the uncommon mutations. So osimertinib plus chemotherapy, amivantamab lazertinib. We have, the consideration for second generation inhibitors like afatinib, which have shown in some retrospective series as well as a prospective study, reasonable activity against the uncommon mutations, though at some cost, I think, of CNS activity and toxicity profile. And we also have the consideration for some of these novel agents through clinical trials. So I think that treatment choice has become quite complex and likely involves a balance of our understanding of the specific uncommon mutation, what we know about its sensitivity to current available drugs, the need for CNS activity. So does the patient have CNS mets or not at baseline, for example? And of course, patient wishes and preferences around side effect profiles, balancing against what the clinical needs might be of that scenario. So in some ways, almost a more complex decision than we have even for our classical EGFR mutations.
But I do think it's an exciting time because we're starting to see clinical data on more and more options for this class of EGFR mutations.
Yeah, absolutely agree. And hopefully to see some combinations coming with these sort of uncommon mutations with some of the novel agents, plus things like amivantamab or chemotherapy, I think will be fascinating as well. And hopefully give us a chance to offer our patients more and more effective strategies here. Now, one topic that I think has been complex for lung cancer as a whole, including EGFR lung cancer, has been the topic of the PD-1 VEGF bispecifics. And there's numerous actually in clinical development, none approved in the US at this time. I think ivonescimab has been furthest along, and we've seen data for that in the EGFR space previously in the Harmony study, which looked at this agent, which is a immunotherapy VEGF blood vessel modulating agent in combination with chemotherapy in EGFR mutant lung cancer. Of course, there are other agents. There's pemidomig, which is an agent in development, as well as ZPF404. So there's a number of agents out there that you might see in clinical trials looking at this class of drugs. So we hear a lot about it. And I think in EGFR, that's always been very interesting. So we think of EGFR as being a cold tumor, right? A cold tumor microenvironment and not sensitive to our typical available immunotherapy agents. Yet we're suddenly seeing some data about these PD-1, which is an immunotherapy checkpoint bispecifics, showing up in the EGFR space. Outside of EGFR, there was one of the plenary sessions at ASCO was the Harmony 6 trial looking at ivonescimab, again, one of these PD-1 VEGF bispecifics in squamous cell lung cancer. So not an EGFR mutant lung cancer, but still in the frontline setting for squamous cell lung cancer. And it made a big splash because it showed not just improved progression-free survival, but also improved overall survival, though in an international only, so Chinese only patient population, with ongoing global studies looking at this, trying to confirm this in an even broader set of patients who've enrolled on a trial. This is a controversial question. I think no one really knows what to expect from these agents, but thinking about the EGFR space, we get a lot of questions about this, I think. How should we think about planning for the future? Will these, where these might fall if they become available for patients with EGFR mutant lung cancer? Is there a role for these bispecifics?
I think it is an exciting time since it is a new modality that we have not had before. And as you mentioned, Dr. Rotow, the classical immune checkpoint inhibitors do not work in EGFR mutant lung cancer, but clearly the data from the Harmony study, as well as from some of the other bispecific studies, show that there is a potential for this class of agents to work in the EGFR mutant lung cancer. So far, they've been given together with chemotherapy. Of course, the possibility exists that these agents could also enhance the efficacy of some of our other recently approved therapies, such as antibody drug conjugates. So we'll wait and see for that, whether this class of agents can be given together with with EGFR kinase inhibitors such as osimertinib, I think also remains to be determined. In general, immunotherapies in combination with EGFR small molecule kinase inhibitors have been toxic, including with osimertinib. So that may also extend to this class, but that will be a question that we'll try to need to address at some point in the future. But this will, assuming that there'll be an approval of ivonescimab or some of the other PD-1 VEGF and bispecific antibodies, this will add another agent that we can use to treat our patients. And I think the next couple of years will be spent refining and defining where and when this agent has its best efficacy and in what setting and with what combination partner.
Yeah, so agree. I think really exciting to see novel agents, novel drug classes showing activity here. And like you said, in the next challenge, really very good challenge is going to be sorting out how do we use these most effectively together in combination in sequence, to get our patients ideally the best possible outcome. So I think we're all looking forward to tackling that challenge and happy to see progress occurring in the field. And with that, thank you for joining me for this conversation. I think it's exciting ASCO this year for lung cancer as a whole, including EGFR mutant lung cancer. We'll look forward to bringing more updates in the future.
Thank you for joining us.